Hi, I'm Dr. David Macias. I'm an orthopedic foot and ankle surgeon here at OrthoVirginia. And I want to first of all say thank you to everyone who's tuning in to this Facebook Live event. Today we're going to be talking some about chronic ankle instability. But before I get into that, I just want to say a little bit about OrthoVirginia. We are an orthopedic specialty practice with offices throughout the state of Virginia. And we are the proud orthopedic and sports medicine partners of the Washington Commanders. And we take care of the recreational athlete all the way to the professionals and everything in between. And so if you have an orthopedic issue that you need some more help with, please visit us at our website, orthovirginia.com. And so without any other further ado, we're going to get into our talk. And so again, as I said, we're going to talk about chronic ankle instability. A couple different types of chronic ankle instability, but the most common is lateral ankle instability. And that's really what we're going to focus on today. Lateral ankle instability is not the same as a lateral ankle sprain. Lateral ankle instability happens after you have a lateral ankle sprain. And we're going to see a person who sustains that right here. This is Neymar. He's a very well-known professional soccer player. He's in a purple jersey with orange cleats. He's going to step right here. And you see that twist, that inversion mechanism. And that is really the mechanism that happens when you have this injury, this lateral ankle sprain. We see it again one more time right there. And if we move on to the next slide, what you injure when you sprain your ankle in this way are the ligaments on the side of your ankle. And those ligaments are two main ligaments. One, the anterior talofibular ligament, and that runs from the skinny bone on the side of your ankle, the fibula, all the way down to your talus, which is the first bone of the foot, and the calcaneal fibular ligament. And that, again, runs from that skinny bone on the side of your ankle, the fibula, down to the calcaneus or the heel bone. These ligaments are very small, and it's no wonder that these are the most commonly sprained ligaments in the body because they're very small, and the mechanisms, the way that our foot and ankle moves, puts them under great deals of stress. Now let's go on to the next slide, please. And so when you sprain your ankle, sprain means tear. And so what happens is you tear the ligaments in your ankle. And you can have we grade these sprains or tears 1, 2, and 3. A grade 1 sprain, if we think of it like a rope, is like a fraying of that rope. A grade 2 sprain is a partial tear, and a grade 3 sprain is a complete tear. And these are MRI images of the ATFL. And what I want to turn your attention to is the kind of thick black line that you see running between the two bones. Now, that may not be obvious to everyone here, but on the image all the way on the left, that is a normal MRI cut of the anterior talofibular ligament. And that's what I want it to look like, a nice thick black line that looks like it's under tension. The image in the middle shows a partial tear of that ATFL where there is some of that black line, but you see a lot of white around it. And that white is edema, and that just goes along with having had this injury. And if we go all the way to the right, what you see is a complete tear. We cannot see any of that black ligament at all. It's been completely torn, and there's a lot of fluid around that area that goes along with having that injury. Now let's go on to the next slide, please. Now, not every ankle sprain is going to go on to chronic ankle instability, but you cannot have chronic ankle instability without having sustained an ankle sprain. Ankle sprains are the most common cause of a missed work time injury here in the United States, and there are about 2 million ankle sprains that occur in adults every year here in the US. Now, that being said, again, not all of them are going to go on to develop ankle instability, but somewhere between 20 to 40% of people will. Now, what you see here on these fluoroscopic videos, these are x-rays that are taken and shot live. And what you see are these patients have chronic instability. In the video on the left, we're twisting that foot, inverting it, and you can see how the talus or the foot is really coming almost all the way out of the joint. Similarly, if you look at the video on the right, you can see how this foot is moving way more forward from where it should typically be. And so we can move on to the next slide, please.
Just a warning that the next slide does include some images that come during an operation. If you want to avert your eyes, we'll let you know when that slide is no longer showing.
And so besides just the pain of that initial sprain or the pain that you may get from having chronic instability, you can have associated injuries with chronic instability. And one of the most common things that can happen is a peroneal tendon injury or peroneal tendon tear, as you see in the image all the way on the left. Now, what happens, the peroneals are a secondary or a dynamic stabilizer to the ankle. And so when the ligaments or the static stabilizers are incompetent, not working correctly, then those peroneal tendons are going to be trying to work even harder to keep your ankle stable. And when that happens, they're more susceptible to injury, and you can wind up tearing those tendons as you see in this image. And the video in the middle, if we could play that again, please, what you see is an injury to the joint surface. The joint surface is white, and you can see the probe running over it and then dropping into a hole. And essentially what has happened is with the ankle sprain, this patient, or with the ankle instability, this patient has actually scuffed off or taken off a piece of cartilage from their joint. Eventually, if that builds up over time, what happens is you can develop ankle arthritis, as you see in the picture all the way on the right. Ankle arthritis is not like hip or knee arthritis. It does not occur just from having reached a ripe old age. Ankle arthritis occurs when you have either chronic ankle instability or you have had a really severe ankle injury. So there's always some degree of trauma, almost always some degree of trauma associated with ankle arthritis. Let's move on to the next slide. And so when people come to see me and they've had chronic ankle instability, there's always a history of having had an ankle sprain. Now that sprain may have been 1 year, 5 years, 10 years, 20 years ago. But since that sprain, people say, I just never got all the way better. I never felt like my ankle was ever stable again. They'll often say, I don't feel like I can trust my ankle. I don't feel like it's strong enough. I feel like it's weak. I feel like it's easy to turn or twist their ankle. They'll often report that they have swelling at the end of the day, even if they didn't really do any particularly strenuous activity. Now on exam, people will often have pain over the anterior lateral ankle or over the outside part of their ankle joint. They'll often have swelling there, and they can have increased motion to a drawer test, and that's what you see here in this video. And this is essentially what was being done on the fluoroscopic video we saw previously. This is what it looks like in real life, pulling that ankle forward, pulling the foot forward in relation to the ankle to see, is there more motion there than on the other side? Let's go on to the next slide, please. For any patient, either with an acute ankle sprain or with someone who has developed some chronic ankle instability, the first line treatments are always conservative. We start with things like physical therapy, and with that, they do a lot of proprioceptive training, gait training, ankle stabilization, things of that nature. Bracing can be very helpful, and depending on the degree of instability that you have, it may be bracing full-time, and maybe only when you are doing high-impact activities. Anti-inflammatory medications like ibuprofen and Aleve can be very helpful at reducing pain and reducing inflammation if patients are able to tolerate and take those medications. And activity modification can be helpful, but this is one we try to avoid. Activity modification sounds really great, but really what it means is not doing things that hurt it. And in the short term, while you're doing the therapy and the bracing and the anti-inflammatory medications, activity modification is a good thing to help prevent having a second injury and let you to heal. But obviously, our goal and my goal of treatment for patients is to be able to get them back to whatever activity they so choose. Now, if these things don't work, then surgical intervention may be warranted. And so if we go to the next slide, this is just a diagram of what the gold standard repair looks like. And the surgery is called a Brostrom-Gould repair. And this is named after the two people who described this. Brostrom described this repair initially, and then there was a modification that was described by Dr. Gould later. And essentially what is done is those ligaments on the side of your ankle are retensioned and repaired with suture, either suture or suture anchors directly into the bone, directly into the fibula. The Gould modification is what you see here, where that thick band that seems to be draping over the front of the ankle is then advanced into the fibula to give a second layer of strength to the repair. Now, this is the gold standard, and this is excellent surgery for returning people to their desired level of activity. Now, more recently, if we go to the next slide, another newer modification has come about. And this is Brostrom repair with suture tape augmentation. And essentially, the repair is done in the same manner. However, we augment that by putting a suture tape over the top and anchoring that into the talus and into the fibula. And this works as an internal seat belt to prevent the ankle from moving more than it's supposed to. And The real big benefit to this is that we can get patients moving much more quickly, get them through their rehab much more quickly using the suture tape augmentation than with traditional repair. And so for certain patient populations, this can be very beneficial. In conclusion, chronic ankle instability occurs after you've had a severe ankle sprain. Not everyone is going to go on to develop chronic ankle instability, but somewhere between 20 to 40% of patients who have a severe ankle sprain will develop that. There are associated injuries that can occur with chronic ankle instability, and the number one thing that can be a complication is developing arthritis. If conservative therapies like physical therapy, anti-inflammatory medications do not give the relief that patients need, then surgery may be appropriate. So once again, I want to thank everyone for tuning in and listening to me. And at this point, if you have any questions, I'm happy to take those.
Thank you so much. We do have some questions coming in. The first question is that someone has always had weak ankles since they were in high school and played basketball. They're now 65 and the ankles just started hurting again. What should they do? Should they get a brace? Should they talk to somebody?
Sure. And believe it or not, that is actually a very common thing that I see is patients have had injuries a long time ago, again in high school, perhaps even, and then they've dealt with it over the years, and then it starts to hurt again. And I think part of that is because ankle instability, I used to think of it kind of like a light switch. Either you had it or you didn't. Either it was on or it was off. But really, I think there's a very large spectrum of injury. And so you may have some degree of instability that you're able to tolerate for a very long time. And then you may have just one more sprain, one more injury too many. And then all of a sudden now you're in a realm where it hurts to do normal day-to-day things. And so I think, especially if you haven't seen anyone since high school, I would definitely recommend coming in to be seen by an orthopedic foot and ankle specialist because there may be things like arthritis, peroneal tendon injuries, injuries to the joint surface that may be hiding that you may not even know about. Now, again, we would still start with simple treatments like wearing an ankle brace, and you could try to get one over the counter. You want to make sure that you have one that has shoelaces in the front. It's called a corset style brace or a lace-up ankle brace, and taking some anti-inflammatory medication if you can tolerate that medication.
Thank you. The next question is, someone tends to roll their right ankle when they walk, especially if they're walking fast. How can they protect their ankle from injury from the repeated rolling?
Yeah, so a couple things you can do. You can wear an ankle brace when you're walking. And so especially if it only occurs when you're walking fast. So if it's only happening while you're doing this for exercise, then an ankle brace while you're exercising may be an excellent thing to use. You can get what's called a lateral post. And so what this is, it's a small insert that goes in your shoe and it's built up like a pie wedge. And so it's a little bit higher on the outside part of the shoe than on the inside part. What that will do is kick your heel out just so slightly, and that can protect you a little bit from rolling your ankle, depending on the degree of instability on how much it happens.
You mentioned making sure to get a brace that laces up. What's the importance of the laces on the brace?
I just find that there are so many different types of braces out there, and patients usually gravitate to what is the easiest to put on. And the easiest to put on is a sleeve, something that just slips up over the ankle. That, in my opinion, does not give significant support. That really helps with compression. That can help patients to feel better, but it does not give actual stability support to the ankle. And so you may not need, there may be some braces that do not have shoelaces in the front that will be sufficient to give you support. But I know I have not yet encountered an ankle brace that has shoelaces in the front that is not structurally sound to give you the support you need. Now, those braces tend to be slightly bulkier. And so, again, patients tend to gravitate more towards the less bulky items because they're easier to put on, they fit better in shoe wear, things like that. But they may not and typically don't give you the support that you're really looking for that a lace-up or corset-style ankle brace does.
Does a history of ankle sprains lead to overpronation as someone ages?
Does ankle sprains lead to overpronation? It can. So I have seen that happen before. So essentially I've seen patients who've had so many ankle injuries that they have lost the lateral stability to their ankle. And not only have they injured the ligaments, but then they have started to injure the tendons. And so, as I mentioned in the talk earlier, the lateral ankle ligaments are the primary static stabilizer. They don't move. They're just attached between the two bones, and they keep the bones from moving further than they're supposed to. The tendons, the peroneal tendons on the side, are a dynamic stabilizer. And so if you have multiple ankle sprains and you have essentially worn out the ligaments, the static stabilizer, then the peroneal tendons become the primary stabilizer. But they're trying to do a job that they're not meant to do. Those can then become worn out. And at this point, now you have nothing that is restraining you laterally in your ankle, and your foot can start to curve underneath more. So that is something that I have seen happen.
You mentioned the surgeries. Are those surgeries an option if the ankle sprain occurred decades ago?
Absolutely. And I will tell you that is not terribly uncommon that I'm seeing patients, again, who have had a bad ankle sprain in high school or college and are coming to see me, 20, 25, 30 years later, and they've just been dealing with it. And, I think at least when I was playing sports in high school and in college, I heard more than once, hey, it's just a sprain. And what we've really found out is just a sprain isn't always just a sprain. It can be much more severe than that. And so to answer the question, yes, these surgeries can be done even if the sprain occurred a long time ago. The biggest thing is to see, are there any other associated pathologies or injuries that have occurred prior to doing the surgery, to make sure everything's addressed all at the same time.
Are there any exercises you can recommend to do at home to strengthen ankles?
Exercises at home to strengthen ankles? Yes, there are a bunch of exercises you can do, and you want to focus on strengthening the peroneal muscles and on balance. I would really suggest seeing a physical therapist at least once if you are going to start a home exercise program. You can look online and find all sorts of different things for ankle stability, but it's a lot different than having someone show you the correct way to do things and walk you through how it's supposed to be feeling while you're doing those exercises.
Does chronic ankle instability lead to plantar fasciitis?
No, chronic ankle instability and plantar fasciitis are two separate issues. I will tell you, however, I do see a lot of patients who wind up trying to change their gait pattern, trying to change the way that they walk because either of chronic ankle instability or of plantar fasciitis, one way or the other, and developing other problems because they're trying to protect their ankle in a different way. So, for example, I've seen patients who have chronic ankle instability who wind up developing plantar fasciitis because they've changed the way that they walk in order to not put their ankle at risk. And so, no, they're not directly related, but you can have one issue occur because you're trying to protect yourself from the other.
Do you have to have arthritis on an x-ray to have the surgeries you mentioned?
No, actually, I don't want you to have arthritis before you have surgery. The goal of surgery would be to give your ankle stability so that you do not develop arthritis. So again, ankle arthritis develops when you have either chronic ankle instability or if you've had a really bad trauma to your ankle, such as a severe ankle fracture that actually extends into the joint. And so preventing you from getting to that place is the entire goal of ankle instability surgery, to repair the stability to your ankle so that you don't develop ankle arthritis down the road. If you have developed ankle arthritis already, there is still surgery that can be done to help you if conservative treatments fail. But that surgery is not to simply repair the ligaments, it's actually to take care of the arthritis in the ankle.
Does rheumatoid arthritis affect ankle instability?
Rheumatoid arthritis itself does not typically affect ankle arthritis, but I did not mention this earlier. About 90% of ankle arthritis is typically from trauma, but the second most common is probably rheumatoid or rheumatological arthritis. And so Rheumatoid arthritis itself should not affect the instability, but it may lead to ankle pain from ankle arthritis.
What is the difference between the surgeries that you spoke of in the presentation and arthroscopy?
The surgery that I spoke of, the two surgeries I mentioned, are done in conjunction with an ankle arthroscopy. So whenever I do instability surgery, I do put a camera or an arthroscope into the ankle joint to make sure that the joint surface is okay, that there are no injuries to the joint surface. There are some excellent studies that have looked at the results of MRI before ankle instability surgery and before ankle arthroscopy. And what they've shown is that the MRI can often be misleading in terms of injury to the joint surface. And so sometimes it looks like there is an injury and there is not. And sometimes it looks like there is not an injury and there is. And so whenever I do a surgery for ankle instability, part of my treatment is to put the arthroscope or the camera into the ankle joint to make sure that the joint surface looks good. So to answer the question, the difference is arthroscopy is putting a camera into the ankle joint to look at the joint surface and to treat any potential issues that may arise there, such as a loose body, an injury to the chondral surface or the joint surface. The repair is to directly address the instability and to repair the ligaments on the side of the ankle. And I do those when I do the instability surgery. I do the arthroscopy at the same time as well.
Is chronic ankle instability more common in specific ages or genders?
No, not typically. There's not really an age or gender. I would say we don't really see, well, I take that back. I do see some young people, especially as year-round sports are becoming more and more common, who have developed chronic ankle instability. I think the youngest patient I've ever had to treat surgically for chronic ankle instability was 11 or 12, but I've treated people up into their 60s for ankle instability surgically and obviously non-surgically as well.
If someone has an ankle sprain and wants to make sure that they don't get chronic ankle instability, what steps should they take?
The things to do at the beginning are to rest the ankle, to not put it in a situation where it's going to be sprained again. Use anti-inflammatory medication like ibuprofen and Aleve if patients can tolerate that medication. Elevate their ankle, ice their ankle, and give it some support. And depending on how swollen and tender you are, that may range from a cast or a splint to a boot to an ankle brace to just wearing supportive shoe wear. And so those are the things to do initially. As I had mentioned earlier, the vast majority of people are going to heal a single ankle sprain on their own without any type of surgical intervention. But the people that I find that get into trouble are the ones that have an ankle sprain, are trying to push it too quickly, and then have sustained a second ankle sprain while that ligament is still healing. And that's when I think people really get into trouble and are more prone to develop chronic ankle instability.
You said that ankle arthritis is usually caused by trauma. Would a broken ankle count as one of those traumas?
Absolutely. A broken ankle can count as trauma for that. And so it just depends on how much displacement you had at the time of injury. If there was a joint surface injury at the time of the fracture, there are a bunch of different factors that go into that.
Can ankle instability cause Achilles tendon problems?
Again, as we talked about with the plantar fasciitis, not directly. The instability does not directly affect the Achilles tendon. But I have seen people who are trying to change their gait pattern, change the way they walk, change the things that they do, and they wind up developing other injuries or issues because they're trying to protect either their ankle or their Achilles tendon. And so I've seen it happen in that manner. I have seen a lot of times when people have had an ankle sprain and I have immobilized them, and the Achilles tendon will get tight very, very quickly. And so even after a brief period of immobilization, the Achilles tendon may feel slightly tight after that. So I have seen that frequently.
Thank you so much. That is all the time we have for questions today. If you asked a question while we were live and we have not yet answered it, we will answer it in the comments. Dr. Macias, would you like to close?
Oh, absolutely. Thank you again, everyone, for tuning in. I really appreciate it. Again, if you have any issues or questions, please feel free to visit us at orthovirginia.com. We'd be happy to see you. Thank you.